Hi, my name is Michelle Williams. I'm a Quality Improvement and Practice Support Consultant at CHEC. We've been getting a lot of questions about the proposed rule, and we wanted to make a tool available to all of our practices and anyone who has any questions or concerns about the proposed rule and what it means for their meaningful use attestations this year. So the proposed rule has not officially passed as of the date of this recording, June 10th, 2015. However, the comment period has passed, and we do expect a final decision in August and September, around that time period. We do expect that the proposed rule will go forward pretty unchanged from what we are presenting today. It was an attempt to make meaningful use easier to meet, especially for providers who were expected to meet meaningful use stage 2 this year. And it is also an attempt to get everyone on the same stage. No more split stages. So they're trying to get everyone on what they call a modified stage 2. In larger practices, you may have some providers who are on stage 2, some providers who are on stage 1, year 1, or stage 1, year 2, etc. So the goal of the proposed rule is to get everyone on a more even playing field on these modified stage 2 measures. So what we typically recommend is make sure you know what stage you are currently in. Are you a stage 1, year 1, stage 2, year 1, or stage 2, year 2? Determine if you are truly a stage 1 or a stage 2 provider. If you're not sure, you can log in to NCTracks or CMS to see what you've been paid for so far. You'll also want to run a recent 90-day report to determine what measures you aren't currently meeting. So we recommend doing sort of like a gap analysis. Ideally, if you can in your EMR, go ahead and run a stage 2 report, even if you are only supposed to be reporting for stage 1, because some of the stage 2 measures are slightly different, such as the e-prescribing with formulary or VDT measures, the view, download, transmit measures. So go ahead, if you can, run a stage 2 report for 90 days just so we can get a general idea of where you stand. And develop a plan for meeting the measures that you are currently not meeting. Highlight the ones that are still going to be staying in the proposed rule. We're going to go over what measures are dropped and what measures are staying. And reach out to your CHEC consultants. We work with a lot of EMR vendors. I personally have a lot of experience with Allscripts Amazing Charts. Jessica on our team has a lot of experience with Practice Fusion. Sonali has experience with NextGen. So depending on what EMR you have, it's a good idea to reach out to your consultant and say, we're not currently meeting patient education. Do you know someone else who uses Amazing Charts that is meeting patient education? Can you help us figure out what we need to do to meet that? And of course, you can always reach out to your vendor and customer support to figure out why you're not meeting that measure. Some things to remember about the proposed rule is that it does allow everyone to report on a 90-day reporting period this year. Even if you were supposed to do 12 months, you can do 90 days. Some measures are being removed for reporting purposes, but you should still be doing them. In a little while, we're going to go over the measures that you are no longer going to have to report. But CMS believes that the reason they're removing them is because they are so ingrained. Practices are doing them now, and they don't need to keep asking you to report on those measures, such as demographics or patient lists. They believe that these basic chart-keeping tasks are being built into workflows, and they don't want to keep asking about performance on measures that you've already proven several times you're quite competent at. There will be no difference between core and menu measures. All remaining measures left after the proposed rule are required for passing, so it's all or nothing. In previous years, you could sort of pick and choose your menu measures, and if you couldn't meet all menu measures, that was okay because you only had to meet, 3 or 5 of them, depending on what stage you were in. But since they're removing so many measures in the proposed rule, what this means is any remaining measures, you have to pass them all. So these are the measures that they're going to remove in the proposed rule. And some of them, as I discussed earlier, are things that you've really built into your practice workflow: demographic, vital signs, smoking status. CMS believes that most providers are so good at doing this, they don't need to continue to monitor your performance. But again, they do stress that you need to continue to do these things. Another thing to remember, especially if you are a PCMH practice, is that even though these aren't required for meaningful use, you won't have to report on them for meaningful use this year, they are still required to maintain your PCMH certification. So I don't want to let you slip back on anything thinking you don't have to do any of these things, when to maintain your PCMH certification, you should still be doing them. So if all of these measures are dropped, what's left? Because so many measures, as I said, are being removed for reporting purposes, but you should still be doing them, all of the remaining measures are must passes. So there's no picking or choosing mini measures. All of the measures that we're going to go over next, you have to pass. There's little wiggle room. So meaningful use, stage 2 or stage 1, depending. You had core measures, menu measures, reporting your clinical quality measures, and then you got meaningful use. So in stage 2, you had 17 core measures. You had to meet at least 3 menu measures. You had to report on 9 CQMs or clinical quality measures. And that's how you got a successful meaningful use attestation. That's the old way. The new way is you're going to report on the 9 remaining measures, sometimes they're called objectives, public health measures, and the 9 CQMs, which stay the same. So these are the measures that are going to stay: CPOE, e-prescribing, clinical decision support, patient access, which is the patient online access. We'll discuss some of that. You have to have a patient portal to meet meaningful use. Protecting electronic health information, that's also known as the Security Risk Assessment, or SRA. Patient-specific education, medication reconciliation or inbound referrals, summary of care or outbound referrals, as they're sometimes called, and secure messaging. There have been some changes to the thresholds, and there are also some exceptions if you were supposed to be stage 1 this year. We're going to go into it in a little bit more detail. So again, what if I was supposed to be stage 1 this year? So for 2015 only, there are special exceptions for eligible providers who would have been stage 1. Where thresholds or objectives conflict for the same fundamental objective, more recent enrollees only need to meet the lesser of the requirement between what was 2014 stage 1 and 2014 stage 2. An example is the e-prescribing measure. If you were stage 1, only needed to be 40%. The threshold for stage 2 is 50%. If you were supposed to be stage 1 and you couldn't quite get up to 50%, you can report 40% without any penalty, and it doesn't have to include the formulary checking. However, I will say that the consultants at CHEC would probably advise, to make your life easier when it comes time to attest, try for the stage 2 measure of 50% with formulary checking, so you don't have to claim exceptions and possibly make yourself slightly more susceptible to an audit. So we encourage everyone to shoot for the higher stage 2 objectives, and if you can't meet that, just know that you can still fall back on the stage 1 version of that measure. So CPOE, the stage 1 threshold is 30%. There's an exclusion if you wrote less than 100 prescriptions during the reporting period. The stage 2 threshold is 60%, and the same exclusion. Not a whole lot of changes here, but if you were stage 1 and you couldn't quite get up to 60%, you can still meet this measure with just the 30%. E-prescribing with formulary, stage 1, 40%, unless you wrote less than 100 and did not include the formulary. In stage 2, it's 50% exclusion if less than 100 prescriptions written during the reporting period. Again, we would recommend making sure formulary is turned on and that you get this numerator and denominator from your meaningful use stage 2 calculator, even if you should be reporting for stage 1. Just a reminder that on these measures that are staying here, it doesn't matter if you were supposed to be stage 1 or stage 2. These are the measures that you're going to be reporting. I'm just letting you know that if you are stage 1 and you can't meet the higher threshold that's required for stage 2, you can go back to the stage 1 version of that measure. But the actual measures themselves are the same regardless of what stage you are supposed to be on. Clinical decision support rules. Stage 1 version just says 1. Stage 2 version says 5 clinical decision support rules. And a clinical decision support rule is any sort of pop-up reminder built into the EMR. A lot of software vendors have clinical decision support rules automatically built into their EMR. You just got to ask the vendor, what are they? Some of them require that you activate them. Some of them require you custom build them in. An example of a clinical decision support rule might be cancer screening reminders, hemoglobin A1C reminders for your diabetic patients, asthma action plan reminders for pediatric patients, flu vaccine reminders, pneumococcal vaccine reminders. There are all types of reminders. So just ask your vendor if these are built in, or do you need to custom build them? Do you need to activate them? Even if you are stage 1, I would probably go ahead and recommend trying to go implement 5 clinical decision support rules, just so you don't have to worry about it this year and you don't have to worry about it next year. Patient online access. So this is the patient portal. And this was one that a lot of providers struggled with. How am I going to get 5% to go online and view, download, or transmit or transfer their clinical summary or their health information? So what we're saying is go ahead, make sure you have at least 50% of your patients. For the first part of this measure, make sure you have at least 50% of your patients signed up on the portal. And for the second part, the VDT measure, you need to have a report that shows at least 1 patient per provider went online and viewed, downloaded, or transmitted their information to prove that it works. So again, no, you don't have to meet that 5% threshold anymore. You just have to have at least 1 patient. A reminder that you will not meet MU without a patient portal. It is required. So the SRA, Security Risk Assessment, or sometimes called a security audit, is very similar, or pretty much the same really, what you did last year. We did make a video last year, and the link is here. We can email these slides to you or email you that link. But the security risk assessment, if you did it last year, you just need to update it this year with any changes that you made, an updated inventory perhaps, or any security improvements that you made for the practice. CHEC practice consultants cannot complete the SRA for you. We can give you sample policies, video tutorials that we've made, and if you feel that you cannot do your own SRA, we can give you a list of vendors in the area who can help you complete that. And again, I would really check out that YouTube video we made last year. I've had a lot of providers say it was very useful. I will also let you know that this is an attestation measure. You don't report a numerator or denominator. You simply say, yes, it has been completed. But if you get audited, this is the number one thing that they are looking for. A lot of people just click the box, yes, we did a security risk assessment, and then when they get audited, they can't actually produce it. Just want to let you know, this is the number one item auditors will request. So you want to make sure you have it completed, because you could get a prepayment audit and they will not pay you until you produce evidence that this was completed before you attested. Patient-specific education, 10% threshold for either stage 1 or stage 2. That has not changed. Same thing with medication reconciliation, also known as inbound referrals, 50% threshold for either stage 1 or stage 2. Summary of care. This is tricky. This is the major problem with a lot of our practices. So when looking at this measure, this is the first thing I'll say. Run a 90-day report, a recent 90-day report for this year, and determine if each provider has less than 100 referrals during the reporting period, during a 90-day period. Because if your provider's in a 90-day reporting period, typically only refer 60 or 70 times in 90 days, then we're going to choose not to stress out about this measure, because you can take an exclusion if you have less than 100 referrals in a 90-day reporting period. Now, if your providers are close, if they're 89, 95, they're really close to having 100 referrals in this 90-day reporting period, we're going to have to figure out a way for you to meet the 10% threshold of doing referrals electronically. And what we have found is you can do it with the hospital. The hospital does have a gentleman, his name is Dennis Anderson, and he can help you do some direct test messaging with the hospital. And the reason we recommend that is because their cardiology practice is so large. A lot of our providers, at least 10% of their referrals are actually cardiology referrals. So if that's the case, we can help you get in touch with Mr. Anderson at NHRMC, and they can do some direct messaging test exchanges so you can start sending your referrals to their cardiology group electronically. You can also do it with any other provider who uses your EHR. eClinicalWorks has that P4P provider, P2P, the provider-to-provider direct messaging system they have. That'll help you meet that measure. Amazing Charts, we have a lot of providers on that. You can do referrals that way, but you need to find a way to do 10% of your referrals electronically, and you can either use Direct Trust, which is what we recommend, or the HIE, which could be Coastal Connect HIE. I will say that doing it with the HIE is a little bit tricky because sending your referrals to the HIE may not calculate in your meaningful use calculator from your EMR vendor. And so then you'll somehow have to create a manual report proving that 10% of your referrals were completed using the HIE. So think of it this way. Run a 90-day report, see if you're close to 100 referrals per provider. If you are, feel free to reach out to your practice consultant and say, help me get in contact with Dennis Anderson. We need to do some direct messaging testing to see if I can't send direct messages to any of the NHRMC providers. I will also let you know that Wilmington Health, as of right now, is not doing direct messaging. So if we find out at any point that they are going to be doing direct messaging, we will let you know. And we have a lot of providers who do refer to Wilmington Health specialists, but at this time they are not doing direct trust referrals or electronic referrals. Secure messaging. This was also one that a lot of providers were struggling on how they were going to meet it. It required 5% of your patients to send you some sort of secure message or two-way messaging from your patient portal. So this has been changed to no longer having a threshold. You just have to attest that this functionality is enabled. We would recommend having a report that shows that this has actually worked. So if you could get some patients to message you, just in case you get audited and they say, prove that this functionality was enabled, you can say, well, look, I've got a list of patients who did send us secure messages during the reporting period. Just to sort of, cover your end should you be audited later on. So public health measures are now combined into a single objective. So if you're stage 1, you only have to report one public health measure. If you're stage 2, you're supposed to do 2. So we'll discuss what this means and what options you have. I will let you know that you only need to be actively engaged instead of ongoing submission. So even if you're not providing data to the cancer registry, for example, if you are actively engaged and have a contract in place to begin transmitting data to the cancer registry, that's all that you need to meet this requirement. So there are some exclusions, especially in North Carolina, because North Carolina does not have a whole lot of resources available. Immunization registry, you can take the exclusion because it's not available in North Carolina. Syndromic surveillance is not available in North Carolina. Public health registry reporting, this could be met with NCHIE. Again, you just have to meet actively engaged, not ongoing submission. And I have a contact over at NCHIE. Her name is Jill Bosel, and she can help if you are on board with the NCHIE. She can help you get some documentation saying that you are meeting this measure. And clinical data registry reporting, and that includes ACOs and other non-governmental groups. So we do recommend that everyone sign up for the cancer registry. That's really the only big functioning registry in North Carolina. There's an exception for providers who feel comfortable attesting that they do not directly treat or diagnose any type of cancer. If you feel comfortable stating that you don't directly treat or diagnose any type of cancer, you can take an exclusion on that. I will say I have a lot of providers, though, who in some form or fashion, even if it's very minor and they'll eventually refer out, do directly treat or diagnose cancer on some level until that patient can see your specialist. So, clinical quality measures, or CQMs, they stay the same. There's no change from last year. So you'll need to report 9 clinical quality measures out of 3 of the 6 domains. And your CHEC consultant can help identify which measures you can report on. A lot of it is dependent on what your software vendor, what measures they are certified to produce. There are no thresholds for CQMs. If your numerator is 0 and your denominator is 93, that's fine. You're passing. I would say just try to find a measure you've got some data on, even if it's your numerator and denominator is 1 out of 102. It just looks a little bit better than reporting all zeros. Might make you slightly more susceptible to an audit if you report all zeros for all of your clinical quality measures. So try to find measures that are applicable to your practice. And again, your CHEC consultant can definitely help you identify 9 measures out of 3 domains that will help you meet this part of meaningful use. So people hear that the reporting period is going to be shortened for 90 days, and all of a sudden we get asked, when can we attest? I've got a passing report for 90 days. When can I go ahead and attest? So a reminder that as of time of this recording on June 10th, 2015, the proposed rule has not officially passed. But we do expect to have a final decision of the rule in August or September. We do expect it to pass pretty much as is, as we've explained, the measures altered a little bit. So remember that once the rule is passed, it will probably be some time before CMS and NC Tracks. They all have programmers that update the algorithms on their websites that you go and attest on, and it might be a little while before those algorithms have been reprogrammed on the website, so you may not be able to attest immediately. But as soon as we hear any final confirmation that the proposed rule has officially passed, or that the attestation websites, either CMS or NC Tracks, has been reprogrammed and are ready for attestation, you can go and do this. We will, of course, let you know immediately. So I'm sure that you'll probably have some questions or concerns, and here's our contact information. You can contact our director, Sonali Badish, Jessica Reed Williams, or myself, Michelle Williams. And if you are unsure of who your consultant is, or maybe you haven't been getting CHEC services recently, you are always welcome to email recteam@chec.net. This is an email that will go to everyone on our team, and one of us will get back to you as quickly as possible. We hope this helped explain the proposed rule, and always know if you have any questions or concerns, you can always email or call our team. Thanks, and have a good one.